Good morning, everybody. On behalf of the Saudi Group of Pediatric Ophthalmology and Strabismus, I would like to welcome you this morning to our combined teaching round. We have a group of excellent fellows that will present some difficult cases, and we're very excited to have a fruitful discussion from our panelists, and thank you all for the contribution. We'll start with our first case. The first case is titled Congenital Partial Third Nerve Palsy with Aberrant Regeneration. It will be presented by Hind Al-Hadali from Prince Sultan Military Hospital and Dr. Amal Hmedan. Please, Hind, share your screen.
Okay.
Hind is an F2 currently.
Do you see my screen now?
We do. Please use the, okay, go ahead.
Yes, good morning, everyone. It's my pleasure to be here. And I would like to thank all the doctors organizing this nice meeting. This is supervised by Dr. Amal Al-Hamida. We entitled Partial Congenital Third Nerve Cranial Palsy with Aberrant Regeneration, but there is a surprise at the end. So this is a 7-year-old girl with right face turn since the age of couple of months. It is increasing with time, according to her mother. The mother first noticed that the left eye has abnormal movement. Then with time, she noticed the face turn. The baby is a full-term product of a CS section. Natal and antenatal postnatal history was unremarkable, and she was medically free. So here is her video showing at the age of couple months, she has right face turn. Recent examination, as you can see, large right face turn. Her vision uncorrected 20/20/20/30. Her pupils were round, regularly active with no ABD, no anisocoria, and no meiosis on adduction or depression. This is Nangi's photo. On primary position, as you can see, she has a large XT, about 61 prism diopters, which increase in right gaze up to 90 prism diopter with downshoot of the left eye and lid retraction. In the left gaze, she is ortho and occasionally small XT with small left hypertropia. In up gaze, the exotropia reduced to 50 prism diopter, but with the left hypotropia. And in down gaze, it's worse. XT becomes 70 prism diopter with left hypertropia. And this is fixing with the right eye, of course. Extraocular motility in the right eye was normal. In the left eye, she was not able to bring her left eye to even the midline, so it's -5 adduction. Depression is -2, almost 1 to 2 in all gazes. And subreduction was also from -2 to -3, except in left and up gaze was normal. Sensor examination, her stereopsis was 400 seconds of arc. For the test with her abnormal head position, she was able to fuse and saw 4 shapes. However, in primary position, when we force her to primary position, she suppressed the left eye. Fundus photos show no objective intorsion, which would we expect in a congenital third. Subjective refraction in the right eye, she was plano. In the left eye, she had +2 hyperopia with 0.75 astigmatism. Cyclorefraction was quite old, however, it was not remarkable. First section test done in another hospital showed positive for adduction and abduction in the left eye. On MRI of the orbit, there was left medial rectus hypoplasia or atrophy compared to the right medial rectus. Other muscles were normal. MRI of the brain was controversial. The first report was they wrote hyperplasia of the left oculomotor nerve compared to the right. However, when reviewed again with the neuroradiologist, she said it's almost equal in size, and the abducent nerve, 6 cranial nerves on both sides could not be visualized due to image quality. Otherwise, unremarkable. So our differential diagnosis was partial congenital third nerve palsy with aberrant regeneration, or Duane type 4 or synergistic divergence, or congenital fibrosis of the extraocular muscles, type 3 or 5, which usually are unilateral. So we had a bit of a diagnosis dilemma. Is it congenital third nerve palsy with aberrant regeneration or Duane type 4? So I'll speak briefly about these two. In congenital third nerve palsy, it's more appropriately considered a CCDD or also a birth trauma as a left occipital transverse position in spontaneous vaginal delivery. However, our patient was a product of a CS section, cesarean section. And Duane type 4, it's the pathophysiology agenesis of the sex, and part of the third innervate the lateral rectus more than the medial rectus, causing it to abduct on attempted abduction. The clinical picture in congenital third, usually partial, can be without ptosis, variable limited elevation, adduction, and depression, and can be pupillar sparing, and can be complicated with anomalous aberrant regeneration or lid elevation on adduction, or pupil constriction, or vertical exclusions of the globe. In Duane type 4, it's usually absence of adduction with simultaneous abduction on attempted adduction. Regarding the lid changes in Duane type 4, I couldn't find many sources about describing the lid. However, it was either lid fissure narrowing or no lid changes. And they might show aberrant movement of the extraocular muscles, such as a synergistic convergence or downshoot on adduction, similar to our patient, or convergence on upgaze with A-pattern exotropia, also similar to our patient. MRI in the congenital third, it can be either nerve agenesis or diffuse thinning of the third or distal thinning of the third. In Duane type 4, Kim and Huang described MRI finding in 2 patients with synergistic divergence and congenital fibrosis. They demonstrated bilateral hypoplasia of the oculomotor nerve and absence of the abducent nerve. Awaddin and Zidane has reported no abnormalities in their cranial nerve in their 13 patients of Duane type 4. Regarding the management, in congenital third, we have many options, including maximum or supramaximum R&R, or regular R&R with the sound eye left lateral rectus recession, or transposition of the vertical recti to the medial rectus with or without augmentation, suture, or resection. Transposition of the superior oblique to the superior rectus insertion or the medial rectus, or in between. Transposition of the split lateral rectus to the medial rectus. In Duane type 4, Awaddin and Zidane also summarized the literature into either you have to do lateral rectus weakening, either like recession or exturbation or tenotomy, or lateral orbital wall fixation, combined with either medial rectus strengthening procedure, reverse Jensen, inferior transposition of the, inferior rectus transposition to the medial rectus, or superior oblique transposition, or medial rectus strengthening with oblique weakening if we have overshoot in adduction. So this is the video in a recent exam. As you can see here, with with better cooperation of the patient, there is abduction on attempted abduction. She's attempting to rock to her right. So we diagnosed her eventually with Duane type 4. So I would like to ask our panelists, how should we proceed, and do they think it is Duane type 4 or otherwise? Thank you for your attention. These are my references.
Thank you, Hind. We will accept questions through the Q&A. You can see the Q&A. So from attendees, if you have any questions, please type them in the Q&A area. We're glad to have Dr. Ahmed Awadin from the Egyptian Group of Pediatric Ophthalmology and Strabismus join us. Dr. Awadin, can you please tell us your thoughts and comments about this case? I have seen that you have published about the divergence here, as Hind cited. So we're excited to hear your thoughts.
Thank you, Dr. Shahada, and thank you, Dr. Amal, and thank you, Dr. Hen, for this very nice presentation. So obviously, the patient has a true synergistic divergence, or what we call sometimes a Duane type 4. You can notice that there is an abduction movement of the left eye on attempting looking to the right gaze. And peculiarly, usually these patients are also associated with a downward movement. So you can see that the globe not only moves out, but it tends to move down also. So it seems that the patient also has some kind of vertical divergence. And this is very common in patients with synergistic divergence. I'm pointing this because usually whatever you are going to do to the horizontal muscles after surgery, sometimes you can find that this vertical movement persists because you have corrected only the horizontal component, but you can still that the eye will dive down after surgery, even with the horizontal surgery. What we did before that, we did case report. We reported all the cases that we had surgical intervention for patients with synergistic divergence. We had like 13 patients. Of course, not all patients had surgery, but about 10 of them had surgical intervention. And we did a literature review to see what was done before and which surgical strategy was better as compared to other strategies. Usually, we tend to do a maximum recession resection for these patients, but the main drawback of doing a large recession resection is that sometimes you might end up in late undercorrection or recurrence of the problem, and dealing with a recessed lateral rectus very far posteriorly is very hard. So usually, we are inclined to try to straddle the lateral rectus from the start by doing either an orbital wall fixation or by doing a muscle extirpation. This means that we completely remove the muscle. The advantage of an orbital wall fixation as compared to extirpation is that it is somehow reversible. For example, if you got an overcorrection later on, you can just undo the orbital wall fixation, take back the lateral rectus, and suture it to the sclera. Although we have never done this before, but at least it is a potentially reversible surgery as compared to the extirpation. I would like to add something that later on, we have published this review in 2017, but later we reported a new strategy for managing this patient. We can do even what we call a split transposition of the lateral rectus. We can transpose the lateral rectus, do a split transposition, and we can transpose it medially to the medial rectus. The advantage of this strategy is that presumably the left lateral rectus is functioning when the patient is looking on right gaze. So now we have moved the lateral rectus to the medial rectus. So it is supposed to contract now on looking to the right gaze. So it might cause or at least do some adduction maneuver. So by doing this nasal transposition, we are correcting both the alignment in the primary position, and presumably we're going to have some adduction movement because the lateral rectus is functioning on right gaze, and this is the direction of the medial rectus on the left side. But the disadvantage of this technique is that it has to be done in very young children because once the lateral rectus is very tight, there is no way to do this transposition, and you might end up in cutting the lateral rectus, and it will end up in attaching to parts of the sclera behind and make the surgery later on very difficult. But if you have a very young child with this kind of synergistic divergence and the lateral rectus is not tight, we can do this nasal transposition. I would like to know, have you done any surgery for the patient yet or not, Dr. Hind?
No, not yet. Not yet.
So what are you
We
planning to
wanted
do?
to have feedback from the panelists, but I don't know, Dr. Amal, what was your thinking?
For me, I would go for an orbital wall fixation. The horizontal angle is not large, so you can just start with the orbital wall fixation. You don't have to combine it with a medial rectus resection. And later you can evaluate the outcome and the position in the alignment of the eye in the primary position. In rare cases, you might find an overcorrection. You will find that the eye is slightly esotrophic, and in this patient, you can later on transpose the superior rectus to the lateral rectus, like a Duane syndrome. Now it becomes like a classic Duane type 1. And once you transpose the superior rectus to the lateral rectus, you achieve a good alignment in the primary position. But usually what I start with an orbital wall fixation and see what happens.
I have had one case that I had a complete third nerve palsy. I tried to do orbital wall fixation of the lateral rectus, but I found that after a few months after following up that patient, that the lateral is still functioning. So I was wondering if the lateral went back and reattached to the globe. Although I did it with my oculoplastic colleague, so I removed the muscle and he did an external fixation. So I was sure that I did close around the lateral rectus very well. However, I went back and I found some attachment. So I think the pulleys still work, and plus that the muscle will find its way, especially if it's the only functioning muscle in that patient. So I have just had one patient that I did this procedure to, and I wasn't happy with the results. This is just a comment about lateral wall fixation. And I have another question for you, Dr. Awadan, regarding splitting the lateral rectus. I know that splitting the lateral rectus and transposing it to the medial side just gives you fixation. It doesn't give you movement. Even Dr. Daghi, I've heard her so many times discussing this type of procedure, and she did mention that this is just a fixation, so the eye will be fixed in primary position. There will be no function of the lateral rectus, especially that it's a tight muscle and you're really moving it around, and you have to remove both the superior oblique and the inferior oblique to be able to give its proper alignment. So what are your thoughts?
Okay, first thing is very important observations. Yes, in lateral orbital wall fixation, sometimes the lateral rectus might get attached to the sclera and you might get recurrence of the problem. And you have to present this in the first surgery by suturing the intermuscular membrane very well between the muscle and the sclera. So after doing an orbital wall fixation, you grasp the intermuscular membrane above and below the muscle, and you have to suture them together in between the muscle and the sclera. And you have to do this all the way back. And in order to do this properly, you do some kind of a hand-over-hand technique. That means that you suture the anterior part of the intermuscular membrane, the part that you can actually see, and then you pull on the suture, and now you can see the posterior part of the intermuscular membrane, and then you start zipping them from in front, behind, and thus you're closing all the space between the muscle and the sclera, preventing its reattachment to the sclera. So this is very important, what I've already mentioned. I think you have done it from the skin side. Usually suturing of the lateral rectus.
I did do that, but I think it was so deep in and it found its way. I did do closure of the intermuscular attachments. I did separate the muscle from the sclera, or I thought I did, but unfortunately it found its way. And the patient did have abduction after the procedure. So I thought maybe there's some attachment that I have missed, and I went back. And I think it's the pulley. Even if you really, really tighten the muscle and separate it from the sclera, somehow, because it's the only functioning muscle, the connective tissue within the orbit does the abduction.
Yeah,
No,
I think that
other colleagues, Dr. Sesma or anybody else have tried this procedure and did see some residual after the procedure.
Thank you very much. Thank you very much, all of you. I agree with the diagnosis of synergistic divergence of this patient. I agree with Ahmed regarding the possible procedure goes R&R, and well, he says no R&R, probably just lateral rectus orbital fixation. We do a orbital fixation, but we do a modification of the original technique that goes and you fix in the orbital. I mean, in the wall. I'm not fixing anymore in the wall. I'm using a modification that is I dissect very well the lateral rectus, because as Asheda mentioned very well, the pulleys are can be around, no, and acting after the procedure. However, I dissect very well, and I use the needle that is used for the orbital sling, to pass the sutures through the orbital rim, and I reach the external canthal, like a 1.5 centimeters away from the canthus. And I open the skin and I fix it to the skin. So you see how the lateral rectus goes very far away. And that's the way that I found the best work of the when you do orbital fixation. More than be fighting with the wall, I go through the skin, and the outcomes are good. Second, regarding the transposition, the splitting and transposition, I have my doubts. I do at least 10 cases with these characteristics, doing lateral rectus splitting and transposing to the middle rectus, and I don't have good outcomes with this one. I have the suspect, when you read all the literature about that one, is that the superior oblique, in all these papers, the superior oblique is cutted. So I think that the effect that we're getting probably is due to the superior oblique functions, like a abductor, for example. So I'm not sure about this technique. I don't know if I'm doing well or not. I mean, I follow the rules. Once she was, I mean, when it was published, but I don't have good outcomes with this one. One question that I would like to ask in this case is if you measure the secondary deviation of these patients, because I think that probably the secondary deviation in this, the patient is fusing, which is nice, which is important. And probably if we do any R&R procedure, extirpation or whatever, we are going to use the ET. So probably in some point, we need to think the possibility to touch the right arm also. No, I mean, not as a primary procedure, as secondary. I mean, I'm based in the secondary deviation. Why? Because if not, you see the patient has a huge right face turn, which make us, if we want to have something, if you ask me what I would do, well, I would start by R&R, more than R&R, I would do middle rectus resection in the resection in the left, plus lateral rectus orbital wall fixation, and I keep in my hands, like a play card, the possibility in the future to induce ET in the right eye.
Okay. All right. For the sake of time, we'll go to our second talk. We're going to switch the order a little bit. Dr. Shamrani has an emergency, so we'll take his case first. The consecutive hypertropia after inferior rectus Faden operation, presented by our second-year fellow, Lulwa Bubshet. Please start sharing. Lulwa, the mic is yours.
So good morning, everyone. My name is Lulwa Bubshet. I'm a second-year fellow in King Saud University. Thank you. Special thanks to all the organizing committee here. And then I'll start today my presentation about a case we encountered with Dr. Mohammed Shamrani in the clinic. It was a consecutive hypertropia after inferior rectus Faden operation. So I'll start with the first visit presentation with the history. She was a 37-year-old female teacher, medically free, presented with persistent diplopia following a road traffic accident 4 years ago. Initially, the diplopia improved, but eventually become a constant. It primarily occurs when she looks down, especially while reading, and when she looked to the left. Despite a trial of prism glasses, her symptoms didn't improve. So our examination, the first visit, the visual acuity was 20/20 both eyes. She prefers the fixation with the left eye. Anterior and posterior segment were with the normal, and the sacral refraction were mild hyperopia. Our orthoptic examination, first I'll start with the extraocular motility. As you can see here, the right eye, she had a very mild inferior oblique overaction and superior oblique underaction. The left eye was normal. So the deviation in primary position at distance, she had an exophoria and a right hypertropia, right hyperphoria of 2, and at near exophoria of 6. And she didn't have any diplopia in primary position. This is a more detailed deviation measurement in 9 gazes. As you can see here in primary position, as I said, she has an exophoria. And upon elevation, she's ortho. Elevation at right, she's ortho. And elevation to the left, she has an intermittent exotropia and intermittent right hypertropia of 2. In right gaze, she's ortho. And in the left gaze, she has right hypertropia of 12. And down gaze, which is the problem here, she has an ET of 8 and right hypertropia of 7. And she had a diplopia and down gaze. And in down and left, she had an RHT or right hypertropia of 20. When she tilts her head to the right, she has an RHT of 10, and she's ortho with left head tilt. We did a more detailed examination. We did a Worth-4 dot test in all 9 gazes. She confuses in all gazes except in down gaze and left gaze, and with right head tilt. She had an on-off vertical diplopia. We also did a double Maddox rod for torsional deviation. At distance, she had a 15 degree of axial torsion in the right eye, and at near, she had 5 degrees of axial torsion in right eye and 5 degrees in the left eye, a net of 10 degrees in both eyes. She had a good stereopsis with Titmus test. The stereopsis was 100. So at this stage, our impression was an acquired right superior oblique palsy, diplopia and down gaze and left gaze, large axial torsion on double Maddox rod, small V pattern, and no evidence of reversal hyper anywhere to suggest bilateral superior oblique palsy. So we gave her her small hyperopia glasses and a follow-up just to reevaluate and measure the deviation. So in the follow-up visit, there were no improvement in symptoms, same measurement upon examination. At this stage, we had 2 options, either to do a superior oblique tuck or left or Fadden operation. And we proceeded with Dr. Mohammed Shamrani with left eye Fadden operation. So we want to tackle the down gaze. We did this. This is a picture of from Kenneth Wright. We did the left inferior rectus Fadden operation. The force reduction was negative, and so we proceeded with the left inferior rectus Fadden, 12 millimeter from the insertion, using 5/0 Mercivian sutures. So the post-op visit, she came post-op, still complaining, unfortunately, of binocular diplopia in side gazes and in down gaze. Her extraocular motility was changed. The inferior oblique overaction in the right eye is still there. And in the left eye, she had a limitation in infraduction, about -1 to 1.5 to -2. Her deviation in primary position was the same, no diplopia in primary position. She has only exophoria at distant and at near. This is the 9 gazes after the surgery. So it's a bit different from before the surgery. She has an exophoria and up gaze in primary position. But the new thing that she had the left hypertropia of 4 and cyclotorsion and the diplopia and the right gaze. In down gaze also she had an ET of 2, left hypertropia of 6 and cyclotorsion diplopia. And as well in the right gaze, in the down and right, she had a left hypertropia of 12. So we did a more detailed examination to know the problem. The Worth-4 dot test was she can fuse binocular single vision. The double Maddox rod axial torsion is still there, approximately the same amount before the surgery. The fusion in free space is not achieved because of the barrier was the torsional diplopia. And we did a synaptophore examination, simultaneous perception, objective angle was 0, subjective angle was LHT or left hypertropia of 1 plus axial torsion of 5. So with the synaptophore, she can fuse with left hypertropia of 1 and axial torsion of 2, of 5 degrees, sorry. Our impression now, right superior oblique palsy post RTA, post left eye Fadden operation. Unfortunately, we had a consecutive incomitant vertical strabismus, and the axial torsion of approximately 5 by the synaptophore was the barrier for fusion at this stage. So this is a summary of our case today, as we started with right hypertropia and down gaze and left gaze. After the Fadden operation, we had the left hypertropia and mainly in down gaze and in right gaze. So we wanted to take your kind input about the case, and you're suggesting what we can do at this stage.
Thank you, Lulu. So, what are your thoughts? I mean, I'll just make a comment. Then Faden is a reversible procedure, fortunately. So I think this can be undone. I don't know, why did you choose Faden versus a right inferior oblique recession or a myectomy? So Dr. Shamrani, can you please
Good
let
morning.
us
Thank you all.
Morning.
Thank you, Dr. Lula, for presenting this case. Actually, because her problem mainly in down gaze and left gaze, so I thought that if doing just right inferior oblique surgery, it will not help her much, because the area of the hyper is more in the not in the field of inferior oblique, and her inferior oblique of her axis minimum just +1. So I did not think that the doing surgery inferior oblique will help her. So I ended up with looking to something that can affect the left and down gaze more. So oblique tuck was an option, but I thought that since he has almost no hyper in primary position, so I thought that doing inferior rectus Faden may help her to tackle this inferior oblique of fraction down gaze without affecting the primary position. We end up with good result regarding the left hyper, but right hyper. But now she end up with this left hypertrophy in the right gaze, which is I don't know why it happened, and the cyclotropia. Cyclotropia from the Maddox rod measurement is low, it's not that high. So I think maybe if we correct the vertical element, you can overcome this. Now, do reversing Faden now will help her after like now 4 months from surgery? I'm not sure. Want to hear the opinion of others. And if they think what to do for this left hyper and the right gaze. It's almost reversing the initial picture of the patient. So it was right hyper and left gaze and down gaze. Now it's left hyper and the right and down gaze.
Did you get an MRI to check the superior oblique muscle size? I mean, if you wanted to do a tuck, if you had an atrophied superior oblique, then maybe a tuck can help her, even if it's a small tuck, especially that she had a torsion initially. So, and a Faden will not help her much with her torsion, but a tuck or an inferior oblique will help in the torsion element. Dr. Awadain, what are your thoughts?
Thank you for the nice case. Okay, the problem of patients with acquired superior oblique nerve palsy is that they are different from the congenital type. For the congenital type, usually anything would work and inferior oblique weakening would work. Adult patients are very difficult to manage. They have a very, very narrow fusional range and they have to be perfectly aligned. Sometimes you would have double vision for a very small hypertrophy and very small torsional deviation. And sometimes they might even have a central loss of fusion. So even if you place the eye perfectly well, they will still complain of double vision. The good thing about this patient is that she can fuse with a synoptophore, so at least we know that we can do her something that could help her. Now, for me, this patient had a V pattern and she had a large torsional component. I mean, 15 degrees is quite large for to be able to fuse. I mean, I would have tackled the torsional component in the first surgery. Probably I would have liked to do her, even if I'm not going to do a tuck, I would do a Harada E2, for example, or I can do even plication of the anterior fibers of the superior oblique. But I mean, I need to correct the ET in down gaze. I need to correct the torsional component, at least in the first operation. Now, the problem is that you have a very small vertical component that increases in down gaze. So you need to work on muscles of the down gaze. So an inferior oblique weakening wouldn't help a lot. So obviously you have either to do a superior oblique tuck, which as Dr. Muhammad said, the angle is very small. So you might afraid of overcorrecting her or getting an acquired Brown syndrome, but this is an option. The other option is to work on the yoke muscle, which Dr. Muhammad did, is to do an inferior rectus weakening. Probably have done like an inferior rectus recession. Dr. Muhammad did a Faden, which might be too much, but at least it is an option. It's a very valid option in these patients. So why did the patient get an overcorrection? What I would think of is one of two things. One of them is that we have induced a flapper. The inferior rectus is peculiar from other muscles, is that the orbital fibers are actually, you can see them during surgery, attached to the pulleys and to the lockwood ligament. So sometimes during posterior dissection, in order to be able to do a good Faden sutures, you might end in causing some kind of a flap tear in the inferior rectus, and this might cause an excessive weakening of the inferior rectus and might end up in a consecutive hypertrophy. The other thing that I might think of is that we have included accidentally or even not accidentally, sometimes it might get attached the inferior oblique. So sometimes if you have included the inferior oblique in surgery, you might end up in this overcorrection. So as you have mentioned, Dr. Mohammed, I would probably try to undo the Faden procedure. I think there will be a residual hypertrophy still. It's not completely reversible because usually we end up in some kind of scarring and adhesions. So it won't be 100% reversible, but at least part of the problem would improve. But I would like to add a Harada Ito, for example, or tucking on the right side to correct torsional component at the same time. And I would preferably do adjustable sutures in order to ensure a better outcome.
Thank you very much.
Dr. Ahmed, thank you very much for your input and wise explanation of may what have been happened. Doing the superior oblique, doing Harada Ito, it may not induce torsion in the primary position of gaze.
If doing only on one side, it is not that powerful. You have like 5 to 10 degrees, I think, of torsion in the primary position and 15 in gown gaze. I think the numbers were like 5 to 15. Usually we are able to fuse up to 5 degrees. So above 5 degrees, you probably are going to do a Faden, doing a Harada Ito, and doing it on one side would correct like 8 degrees. So this would be enough for me, just a Harada Ito on one side only.
Good.
So if you have like 15, if we did Harada Ito on one side, we'll end up in like probably 5 or 6 degrees of torsion after surgery, and probably this could be fused.
Good.
Any other comments from any other panelists?
Dr. Sisma, Dr. Saif, raising their hands.
Thank you for the nice case, interesting case. I have a couple of comments. Probably the Faden, as Ahmed mentioned, we need to check. I mean, I agree that we need to undo the surgery, go back and remove the Faden. Second, at that moment, check if we touch the inferior oblique, because you see the Faden was far away. We have common anatomical relations with inferior oblique, and probably the explanation of the left hyperlate is associated to this procedure. If I'm touching the right inferior oblique, probably secondary to this one is that I'm having the left clinic. So probably I would go for undo the procedure, remove the Faden. And I agree also with Ahmed that probably I could do an adjustable Harada. And in case that I need to measuring the patient in the post-op with adjustment, I can control the torsion, the cyclotorsion problem. But probably a small Harada and adjust it and check it in the post-op. But first step is checking the inferior oblique, because most probably has been touched or has been manipulated during the first procedure, and this is the explanation of the left eye.
Dr. Saif?
Yes, Assalamu alaikum. Thank you, Dr. Shamai, for this nice, interesting case. By chance, this patient, if I'm not mistaken, has passed to me before she had the procedure. She passed to me in my private clinic. If I am not mistaken, this is an adult woman that has complaint of double vision. But from the picture that I see, the 9-gaze picture, I saw her main problem before surgery was in the left gaze, which go inside with the right superior oblique versi. Usually the inferior oblique weakening procedure, it's not only correcting the hyperdeviation, it also may correct the torsional component. Anyway, what happened has happened already. So I prefer, as all panels mentioned, that to undo first the posterior fixation, and either you go for mild inferior oblique recession or for the Harada E2 procedure. But I think better to undo procedure first and then re-evaluate again, and then you can re-evaluate here and choose the best second procedure. This is my opinion, but I usually start with the inferior oblique anyway, always, in these cases of superior oblique palsy.
We have a question from the audience. Dr. Nouran Badib is asking, did the prism give her a single image, a down gaze, or she had the torsion? I think if you have diplopia and down gaze, you can put a small Fresnel on the glasses, but I don't think that's something that this patient wanted in particular. Can we have that, Dr. Shamrani?
She used prism before to me, and she was not happy with the prism.
Okay.
So I did not actually get her prism, especially the non-committant strabismus, diplopia, and down gaze. So I thought that giving her prism just to cost her money to make a prism that she's not happy with it.
Another question by Dr. Bashair. She's asking what are the panelists' thoughts about combined resection? I think it's an adjustable Faden to the left inferior rectus and nasal transposition of inferior rectus to correct part of the cyclo.
Yes, both of them are valid option. I was thinking about the nasal transposition, but the only problem of the nasal transposition is that it will increase the esotropia in down gaze. So the patient already started with a V pattern, so probably should get more ET in down gaze.
Yes.
But it would work if you have already corrected the horizontal component in down gaze. As you can see in the surgery here, afterward, the patient had only 2 present diopters of ESO in down gaze, so it might work. The other option is what did you suggest? What was the question? The other option?
I think she mentioned an adjustable Faden, resection, left inferior rectus.
That's not the Scott procedure. Yeah, this is not the Scott suture, the Scott procedure. Instead of Faden, you can do what we said, what we call a Scott procedure. We do a resection of the inferior rectus, but we do an adjustment to combine with adjustable using adjustable sutures. The only drawback for this, for me, at least for the inferior rectus, is that I don't like to place the inferior rectus on adjustable sutures because I'm afraid of getting a late overcorrection, because leaving the muscle hanging back might not attach well to the sclera. So I would like to do it if the patient had a horizontal incompetence, but not for the inferior rectus. But it would work, theoretically at least.
There's another question.
The rate of overcorrection, as you mentioned, is a major thing.
We'll take one more question before we go to the next case. I appreciate it, Lulu, if you can share and then next speaker can share their slides. There's one more question that we can take quickly. How about inferior enterization to resolve the issue?
Inferior oblique enterization?
Yes, inferior oblique enterization.
Too much for this small
the right
angle,
side.
and it will not correct the down gaze. It will just worsen the up gaze. You need to work on the muscles in down gaze. That's the superior oblique and the inferior rectus. We cannot operate on the inferior oblique if the problem is down.
Yeah.
All right.
Thank you. Thank
you. Our next speaker. So we'll go by the order. We'll take Dr. Ghada Al-Qahtani. She will present endophthalmitis in children. Think twice before you diagnose. Supervised by Dr. Musfir and Dr. Khan. Please share a slide. Doctora is from King Khalid Eye Specialist Hospital, and she's currently in F2. Doctora Ghada?
Yes. Good morning, everyone. First, I would like to thank all the organizers for arranging this session. The title of my talk today is Endophthalmitis in Children. Think twice before you diagnose. Starting with the case presentation, our patient is a 6-year-old girl who presented to another institution with the complaint of gradual decreased vision in the right eye for 5 weeks. Neonatal and developmental history was unremarkable. There was no history of prior ocular surgery, trauma, or contact with animals. Upon examination, the uncorrected visual acuity of the right eye was no light perception, and for the left eye, it was 20/20. On slit lamp and fundus examination, right eye showed retrolental floppy mass with retinal detachment and pre-retinal infiltration, while for the left eye, it was completely normal exam. So a clinical diagnosis of endophthalmitis was made in the right eye, and accordingly, vitreous tab with intravitreal injection of cefazolin and vancomycin antibiotics was done. On the follow-up 2 weeks later, there was no change in vision, and examination had similar findings. And in addition, there was MVIs in the right eye and a complicated cataract. 1 week later, the patient came to our ER, and the complaint was no improvement of vision and progressive leukocoria, again in the right eye. Clinical examination, the uncorrected visual acuity was light perception in the right and 20/20 in the left. Intraocular pressure in the right eye was 30 millimeter of mercury, and in the left it was 15. Extraocular motility and external examination were all within normal. Slit lamp examination and fundus exam showed injected conjunctival vessels, mainly inferiorly in the right. Also, there was a clear cornea, deep anterior chamber with +4 cells. The pupil was dilated and non-reactive. There was ectropion uvea and a retrolental whitish hemorrhagic membrane, and no further view to the fundus. Left eye was completely normal. So after that, ultrasound biomicroscopy was done, and we can see in the above photo there was a ruptured posterior lens capsule with leaking lenticular material. And B-scan demonstrated dense vitreous opacities with an area of acoustic shadowing and calcification. So given the patient's history and the clinical findings, I would like to ask the audience, what is the most likely diagnosis and the next step that you would like to do?
So anyone from the panelists would like to comment?
Yes, I would like to ask, did you do an ultrasound before the TAP? And did you take the TAP and send it to culture, maybe, and also cytology, looking for any malignant cells? Was this done before the surgery, before the vitreous TAP?
The vitreous tab was done in another institution. The patient came to us after the vitreous tab and injection.
So no ultrasound was done before the vitreous tab, no cytology for the vitreous tab. We don't have any kind of information.
No information was
I mean, usually I would be afraid of having a malignancy, for example, a retinoblastoma or any kind of tumor. That's what I would worry about, at least in the first presentation, especially if the patient had no history of trauma, no history of interventions. So I wouldn't go for infection as a primary diagnosis.
Exactly.
Dr. Sesma?
Beyond the suspected infection, one question: when do you see the patient before the injection? Because if there's no history of trauma, is this possible that during the injection they touch the lens and the lens material induce more inflammation beyond of the suspect of endophthalmitis, no? Do you have because it's pretty rare that you have lens material. So during the injection, was a damage or lesion of the lens?
Yes, this is what is shown in the ultrasound by microscopy. There is rupture of the posterior lens capsule, most likely after the injection.
Because this could be another factor. You could have endophthalmitis, but if you add this one, you have phacoanaphylactic and induced inflammation. So you could have malignancy, as Ahmad mentioned. You could have endophthalmitis, but also you are having an ingredient that is you have lens material that is inducing a huge inflammation, so which masquerade everything. Also, of course, you need to rule out malignancies, so MRI, because the calcifications, but also the suspect of why the suspect of endophthalmitis from the onset. And the picture of perforation of the lens is the probably who is masquerading and hiding all the picture, no?
Yes, correct. So given the patient's a history of no prior trauma or surgery, and the patient is systematically healthy, and with the clinical findings of vitreous lesion with calcification, the top differential diagnosis to be ruled out is retinoblastoma, as you all said. So the patient was admitted for further investigation. MRI of the brain and orbits was done, and it showed a heterogeneously enhancing soft tissue mass in the posterior segment of the right eye, with multiple flicks of calcifications, funnel-shaped total retinal detachment, and there was no evidence of optic nerve or intracranial lesions. Examination under anesthesia was also done after that. IOP was within normal in both eyes. In the right eye, there was leukocoria, as we can see in the photo on the right side. There was scleral mild elevation inferiorly, as we can see here. Most likely, this is the area of previous vitreous stab and inject. I mean the area of needle entry. There was a large whitish mass with hemorrhage, can be seen clearly behind the lens. It's also clear in this photo, with anterior chamber seeding of the tumor. Left eye was again completely normal on examination. So the patient's diagnosis of retinoblastoma, as well as treatment options and prognosis, were all discussed thoroughly with the parents, and enucleation of the right eye was carried out. Histopathological evaluation of the enucleated right globe showed iris and anterior chamber angle invasion by undifferentiated retinoblastoma. There was ruptured cataracteous lens with leaking cortical material. The posterior cavity showed vitreous tumor seeding, epiretinal fibrovascular membrane, and superficial optic nerve invasion. There was no choroidal invasion and no definite extraocular extension. So pediatric oncology team was involved, and they recommended adjuvant systemic chemotherapy, and accordingly the patient received 6 cycles. Luckily, there was no recurrence or metastasis over a follow-up period of 6 years. Moving to the discussion, it is well known that more than 90% of retinoblastoma cases are diagnosed by the age of 5 years, and our patient was 6 years, so it was quite atypical. In addition to the atypical age, diagnosis of retinoblastoma can become challenging in the presence of anterior segment or vitreous seeding, leading to the misdiagnosis of endophthalmitis. However, intraocular interventions must be avoided in these cases because of the non-cohesive nature of the tumor and the risk of seeding into extraocular tissues. Looking at the literature, Stafford and his team conducted a study and found that 41 out of 618 retinoblastoma cases were misdiagnosed and mistreated as ocular inflammation, with endophthalmitis being the initial diagnosis in 14 of them. Kalike et al. Found 14 retinoblastoma patients were exposed to intraocular surgeries prior to being diagnosed with retinoblastoma, with the most frequent misdiagnosis being endophthalmitis and the most common surgery being parsiplano-vitrectomy plus minus lensectomy. And 57% of these misdiagnosed cases died over 27 months mean period of because of advanced disease despite multimodal treatment. Meal et al. Also found endophthalmitis to be the most prevalent misdiagnosis in retinoblastoma patients who are aged more than 6 years. This table demonstrates the suggested typical clinical findings to differentiate between infectious endophthalmitis and retinoblastoma. In infectious endophthalmitis, there should be a positive history of trauma or intraocular surgery for exogenous type, or the patient has to be systematically ill if you suspect endogenous origin. The infectious endophthalmitis is usually associated with pain, eyelid swelling, red eye, and sometimes hypopyon and posterior synechia, while retinoblastoma, most of the time it's painless with normal eyelids, quiet eye. Sometimes there might be anterior segment seeding presenting like pseudohypopyon, and there is usually no posterior synechia. Vitreous cells are as expected in the infectious endophthalmitis, while in retinoblastoma, vitreous seeding might be present with whitish clumps. In infectious endophthalmitis, there is usually absence of mass on retinal evaluation and no calcification, while in retinoblastoma, most of the time there is calcification and retinal mass, unless it is the diffuse infiltrating type of RB. So in conclusion, when endophthalmitis is suspected in a pediatric patient, the etiology must be sought, including a history of prior surgery or trauma, or being systematically ill in endogenous endo. Once retinoblastoma is suspected, any intraocular intervention must be avoided until the diagnosis is confirmed to prevent further risk of morbidity and mortality. And upon suspicion of retinoblastoma, the opinion of an ocular oncologist has to be sought. These are my references, and thank you for listening.
Thank you, Ghada, for nice presentation. Actually, the one of the important message from this talk is to know like retinoblastoma can present as endophthalmitis, and as we are all like maybe majority of the audience here are pediatric ophthalmologists or some of the people are in training. It is very important to know that retinoblastoma can present like endophthalmitis. If you have a case in your practice, you think it is endophthalmitis, and because usually who takes care of endophthalmitis? The vitreoretinal team. But before they take care of those cases, usually they involve the pediatric ophthalmologist. So it's good always to really put endophthalmitis, retinoblastoma high in differentials. I'm glad that in the questions and answers, many of the attendees also, they already mentioned the diagnosis retinoblastoma, and they thought about retinoblastoma. So I see Dr. Sisma raising his hand.
Yes, thank you, Abdallah. Thank you, Gada, for this very interesting case. So I would say that we need to tattoo in our brain the word retinoblastoma when we face kids. Doesn't matter if it's endophthalmitis or strabismus or things, because we need to keep this diagnosis in our brain. And second, there was a sign in this patient that caught my attention, and I think that sometimes we as clinicians underestimate, that is the presence of UV electropyon. UV electropyon is telling you that this eye is inflamed, it's chronically inflamed, something beyond of the endophthalmitis is happening there. Also, many times we see it in congenital glaucoma. With UV electropyon is a sign that we need to start looking for it, because it's going to tell us levels of inflammations, levels of complications. It's telling us that the eye is severely sick.
So I just have a comment or maybe a question to Dr. Ghada. Let's say that I'm a general practitioner working, maybe not in Riyadh, maybe working in any part of the country, and I have a patient, and I think the patient might have endophthalmitis. So as we know, endophthalmitis is like when you diagnose endophthalmitis, you have to treat early. And I believe one of the reasons why people do tab and inject, because they want to save the patient eye and they will start the treatment early. But if I have a patient with a pediatric patient and I think it is endophthalmitis, should I treat or should I refer, or what should I do? So Dr. Ghada, what do you think?
So, as we just said, retinoblastoma has to be kept in mind as the top differential diagnosis in any endophthalmitis case, even if if it looks clinically clear. I believe if if the patient is far away or cannot have an easy access to the to institution with ocular oncology service, the ophthalmologist has to discuss it with the ocular oncologist, by phone, or sending them the photos of the B-scan and the clinical pictures. So the seeking of ocular oncologist opinion has to be done.
Exactly. So this is the message. Whenever you have a patient, it is good for us like to see a patient and then say this is not retinoblastoma, and then you can proceed, rather than seeing the patient after the management was done and the management was inappropriate from the beginning.
I think
Yes, I think also that proper imaging is mandatory. Go ahead, Shada, go ahead.
No, please go ahead. I was just going to say that the blastoma has so many different faces that we have to be aware of.
Yes.
The reason. Go ahead, Dr. Ahmed, please.
No, I was just mentioning the importance of imaging. I mean, the patient had the vitreous tab. I mean, he didn't do an ultrasound, and you should always, whenever in doubt, do an MRI. It wouldn't hurt to do an MRI, even if you are not if you're not confident with the ultrasound. Sometimes the ultrasound might point that there is no mass and there is no calcification, but still clinically you are suspecting a retinoblastoma. So there is no harm of doing an MRI whenever in doubt. That's what I was saying.
Exactly correct, because there are few cases, 1 to 2% of cases of retinoblastoma, they do not present with a mass. They present with it's called anterior infiltrative kind of retinoblastoma. So not necessarily that there will be a mass. It could be retinoblastoma without a mass. So always keep in mind this diagnosis, especially if you are diagnosed as endophthalmitis, uveitis, retinal detachment, any cause in pediatric uveitis should consider retinoblastoma.
Thank you all. We'll have our fourth talk. Please stop sharing, Ghada. Okay. Yes, retinoblastoma can present so many different ways. So we'll talk. We'll take our next speaker, Dr. Lujain Al-Qurashi, ocular vertical split, an unexpected post-operative surprise, supervised by Dr. Saif Al-Abaisi. Please share your screen, Lujain.
All right, good morning, everyone. Today I'm going to be talking about an interesting case that we saw in the clinic. This case is supervised by Dr. Saif Al-Abaisi. So this child is a 2-year-old child. She was first referred to our service in 2019 for bilateral congenital ptosis that presented since birth. The child was a product of spontaneous vaginal delivery. She was full term. The patient didn't have any medical issues, no NICU admissions. The parents denied any consanguinity, and there was no family history of strabismus. So on her initial presentation in 2019, the vision was central study unmaintained in the right eye, central study maintained in the left eye. The pupils were fine. The anterior segment and fundus examination were unremarkable, and she had hyperopic astigmatism in both eyes. During that initial presentation, as I mentioned, in 2019, she was very uncooperative, but they mentioned a query -1 superduction in the right eye. She had significant congenital ptosis, mainly on the right side, affecting her visual axis, obscuring the visual axis. So the initial plan at that time, in addition to an ET of approximately 20. So the initial plan at that time was to patch the left eye, give glasses as full cycle refraction, and refer to oculoplasty for her ptosis correction. A year later, after she corrected her ptosis and she came back to our clinic, we saw her, the vision was 2100 in both eyes. The cyclorefraction, she still had hyperopic astigmatism, but what was more obvious in this visit was that she had a bilateral limitation in superduction. In the right eye, there was a -3 limitation in superduction, In the right eye, a -2 limitation in superduction. She also had a significant abnormal head posture. This is a picture that the mother was kind enough to send me, where you can see she has a significant chin up position, although she had already corrected her ptosis. At that time, the orthoptic measurements by Krimsky, she had the 20 prism diopters of ET. She had no evident hypotropia, only the significant chin up. So at that time, the decision was made to go for an EUA with a forced suction test, and depending on that, to go for a bilateral inferior rectus recession with a single medial rectus recession to correct her esotropia. The surgeon was Dr. Saif Al-Abbasi. Based on the results of the forced suction test, which showed significant restriction in the inferior rectus in both eyes, the plan was to go for a symmetrical inferior rectus recession to help the patient with her chin up position, and a single medial rectus recession for her esotropia. In the following post-operative visit, the parents were happy with the result. She had the resolved chin up position, and she still had the limitation in superduction, which is expected. However, on her latest presentation, it's important to note that the patient missed a couple of her follow-up visits and then came to this one. So in the latest follow-up visit, the best corrected visual acuity in the right eye was 20/60, and in the left eye, it was 20/50. There were no abnormalities noted in the pupils, and there was no abnormal head posture when she is sitting in a clinic and looking straight to read the E-chart. The extraocular muscles she had, I'll show you it in the picture. So she had significant limitation in superduction, mainly in the right eye, but also in the left eye. On right and left gaze, there are no abnormalities noted. But if you notice that despite that the patient had limitation in superduction, when the patient attempts to infraduct the eye, the right eye shoots upward, and it's a very obvious and significant upshoot of the right eye. I just want to show you a video of her ductions and vergence. Okay, so this is the vergence. When she's trying to look up, no matter how much she can, the right eye cannot elevate. And when she's trying to look down, there's like a split that occurs between the two muscles. So when she's looking down, the right eye significantly upshoots. And here you can see on the ductions, an attempt to elevate the eye, it's significantly limited, and she cannot. However, when she infraducts, there is this massive upshoot. Her measurements by Krimsky, she had a small hypo in primary position. She had a right hypotropia of 8. When she tries to look up, the hypotropia increased to 18. And in down gaze, as you see, there is this huge upshoot. We also noticed that she has Marcus-Gunn jaw winking phenomena. So when she's moving her jaw side to side, there is an aberrant movement of the upper eyelid. And that's important to mention. So actually, I went back to all of the previous notes, and I asked the parents. No one ever noticed this abnormal upshoot on attempted infraduction. And because we thought maybe it was some sort of aberrant innervation, we decided to go for orbital and brain MRI to make sure that there's nothing going on, and to check the extraocular muscle sizes. So the extraocular muscle sizes came back in the report as insignificant, and upon reviewing it with a neuroradiologist, they mentioned that there might be a slight decrease in the size of the superior rectus muscle, but it's symmetrically, but it's not something that is very significant. So possible reasons of why this occurred. We know that the superior rectus muscle is supplied by the superior branch of the third nerve, and that possibly there is an aberrant innervation going from the branch supplying the inferior rectus to the superior rectus. So when we weakened the inferior rectus in both eyes, when we did the bilateral inferior rectus recession, when the patient attempts to elevate, still, because the patient has a weak superior rectus, it will not elevate that much, same as the pre-op, because that's not something that we corrected. But when she attempts to infraduct, there is an abnormal firing from the aberrant branch that is supplying the superior rectus, which is why she has this upshoot. And as you see, the reason why it's an issue for the patient is because when she attempts to read in primary position, she's okay. But when she attempts to read at school, she's really bothered by it, and she's bullied at school because of this abnormal movement. So our most likely diagnosis, it's most likely one form of the congenital cranial dysinnervation disorders with an aberrant innervation going to the superior rectus, especially given the fact that she has Marcus jaw winking, which is another aberrant form of innervation. We did not do any genetic testing for the patient. However, we would like your input regarding this case and what we can do to help her in this condition, and why this aberrant innervation was unapparent preoperatively, and it started appearing now. Thank you.
Dr. Awadin, can you please give us your thoughts?
Thank you, Dr. Jain. Very nice case. I really like these cases. The peculiar thing about patients with CCDD is that each patient is different and completely unique from the other patient. You cannot find a patient that looks exactly the same. Even for the children or brothers and sisters and the siblings, they all have different phenotypes. Even, they have the same genotype, but each of them has different phenotypic presentation. Okay, what are you presenting now is what they call now a synergistic vertical divergence. So it is different because one eye goes up and one eye goes down. We don't know exactly what's happening in these patients, but we know that it is common in patients with CCDD, in particular after doing an inferior rectus recession. Sometimes it is not obvious, but becomes obvious after doing an inferior rectus recession. What is the cause of this vertical deviation? We have several series. One of them that you have already mentioned. This is a kind of an abnormal or aberrant innervation. So one eye goes down, like the synergistic vertical divergence or synergistic convergence, or like Duane syndrome. So maybe it was present from the start, but it was masked by the tight inferior rectus. But there is always another explanation that this is caused by a problem in the superior oblique muscle. Sometimes, as Dr. Hunter stated or reported later, that these patients have a problem of the superior oblique. They might have either a very short superior oblique tendon, and so once you weaken the inferior rectus, the superior oblique has now the upper hand, so it pulls the eye down and the other eye goes up because it's like a leash effect. You cannot abduct and go down. So once the eye is abducting, the eye will go up. It can only go down when the eye is adducted, and this is causing the seesaw movement. Or it can be caused by what is known as a sagittalization, or actually a desagittalization of the superior oblique. This means that the superior oblique, instead of going back and temporal, it goes straight temporal. And when it goes straight temporal, the action of the superior oblique becomes different, and this prevents the eye from going down. It just lifts the eye up whenever the patient is looking temporal. Well, what is known as desagittalization. This means it is exactly perpendicular to the sagittal suture. And frequently, when you see this patient, you hook the superior oblique muscle, and you can find that they either have a very tight muscle or an abnormal pathway of the superior oblique. And for this patient, once you weaken the superior oblique, at least most of this vertical problem would be corrected. I'm not saying that 100% would disappear, but at least it would improve slightly.
Thank you so much.
Excuse me, Assalamu alaikum. I have a question for Dr. Ahmed. Is there a test to do for the superior oblique to predict or examine before you proceed with any intervention regarding the possibility of superior oblique culprit in this situation?
Yes, you can definitely do a
Is
high
there any
resolution
test like
MRI you can do a high resolution MRI and see the course of the superior oblique muscle, but there is also intraoperatively you can do a force reduction, and there is always the role for exploring the superior oblique muscle. In the past, when I used to do patients with congenital fibrosis, whenever I have patients with this hypertrophy and limited elevation, I just used to do the inferior rectus recession only without touching or looking for the superior oblique. But many instances after surgery, I get this unexpected outcome. I either get this problem, the synergistic vertical divergence, or I get a large exotropia after surgery. So now I have started that whenever I'm operating on a patient with CCDD, I always have to examine the superior oblique muscle. And you'll be amazed that in most of the cases, you will find a problem that should be corrected during surgery. So I always like to surgically explore them.
Okay.
I know that the recommendation in CCDDs is to go with large numbers, and you would always go for an undercorrection. Even if you go for large numbers, the target is undercorrection.
Gotcha.
So I don't have much experience in CCDDs, but if anybody has an experience, please enlighten us. I think these are one of the most hardest, difficult cases to treat, with so many surprises to encounter. We have a question from the audience. What was the ptosis surgery done, and was there any jaw winking before the primary ptosis surgery? So
It's a frontalis sling of the right side. The issue is a patient was obviously very uncooperative in all of her previous notes. So there was no mention of the Marcus gun jaw winking previously, only when she presented to her latest follow-up. When we saw this abnormal movement, this is when I rechecked for Marcus gun jaw winking, and I found it present. So maybe it wasn't obvious prior to the surgery, it wasn't mentioned, or maybe they mentioned it and they did the frontalis sling anyway.
okay.
Very nice case, and even the jaw winking by being bilateral is quite rare. I mean, all findings in these
Very
patients are
rare.
unique.
I actually only found one case. And if you see, she has something called seesaw Marcus gun. I think so. I think she has seesaw Marcus gun.
Yes, she does.
One goes up, one goes down.
One eye goes up and the other eye goes down. It's very, very rare.
Yes.
I think genetic testing is warranted in this patient. You might learn something from the genetic testing as well. Unfortunately, a high-resolution MRI is not obtainable in all centers. So you're lucky if you can have good quality MRIs, but it's not always possible. Plus, like if you want to do very high quality, you would need a motivated radiologist, and you would get quasi-coronal MRI to shift the machine to be along with the orbital axis and not with the patient's axis. So you would need to shift them to get quasi-coronal and get very good muscle sizes with those as well.
Mm-hmm.
What would you see in an MRI of this patient? If we had very high quality, do you expect any findings in the superior oblique, Dr. Awadan?
Yes, either a very short muscle or an abnormal course. I mean, you can see in this photo, for example, when the patient is looking, it seems like the right eye is being pulled up. Usually, the superior oblique is, instead of going behind, being posterior, it's more horizontal. So by being horizontal, it will just cause this vertical upward movement, because usually the superior oblique should be attached behind the globe. So behind the globe, it will cause a depression. But if going dead lateral, it will be attached in the anterior part. So instead of causing a depression, it will cause an elevation. This is what would cause this vertical movement. So this is what I usually look for, what I call a desagittalization of the superior oblique.
And if you note in her down gaze, she can depress only in adduction. So that's another interesting finding in her 9-gaze picture.
Yes, and this is an abnormal course. Yes, this is very true. That's why I'm suspecting an abnormal pathway of the superior oblique.
So would you do a superior oblique myectomy in this case? Or
Complete
free
tenotomy, yes, a complete tenotomy.
Free tenotomy.
Yeah, I mean, I've seen patients like this. I did a couple of these patients before. I know that they do improve, but it doesn't disappear completely. I mean, this vertical movement will become better, but it will not be 100% cured. But at least it will be somehow better.
Okay. Yeah, I think a problem with this upshoot during reading is being bullied at school. I don't think anyone would do nothing to this patient. So I think something should be done. I think I like the idea of a free tenotomy. I see someone, Dr. Abdullah Khan, and there's someone that is an ABC. I don't know who's ABC.
عندك شمراني sorry.
Mr. Shimrani, okay, أهلا وسهلا.
Just question Dr. Ahmed, how do you explore the superior oblique? Where and what you are looking for?
Well, I do a supratemporal, usually start with a supratemporal fornix incision. I hook the superior rectus, and then I hook the superior oblique from the temporal side. Usually, if there is a desagittalization, you will find the muscle anteriorly attach it. So it will not be like 8 or 10 millimeter from the insertion. You'll find it like 2 or 3 millimeter from the insertion of the superior rectus, just temporal to the superior rectus. Then I pass two hooks under superior oblique and I do a complete tenotomy. I can do it either from the temporal side, or I can extend my incision to the nasal side and do a free tenotomy on the nasal side. Another peculiar thing in this photo, if you go back to the photo, you'll find that the patient has an A pattern. This A pattern, again, is highly suspicious of a problem in the superior oblique. You can see when the patient, you can see up in primary position, there is no horizontal component, but once the patient look down, you get a large A pattern. Again, this suggests a problem of the superior oblique usually.
Great. We have one more question.
And you can
through
also
the-
look for the intorsion. I would like one more thing. You could also look for the intorsion of the fundus. You probably will find significant intorsion of the fundi. And I believe that this patient is fixing with the left eye. That's why she's always manifesting with the right upshoot, because she prefers fixation with the left eye. If the patient have an alternating fixation, probably you would have seen the vertical movement on both sides. So when she fixes with the right eye, the left eye will go up, and when she's fixing with the left eye, the right eye will go up. But this patient is like a monofixator. That's why she's always manifesting with the upshoot only on the right side.
Yes.
I have a question regarding what if the superior oblique was found to be normal? Then what is the next step? Will you do the superior rectus recession or Faden, or because at primary she looks okay, but our problem when she looks down.
No, I would probably still go for the superior oblique. I mean, I wouldn't do a superior rectus weakening here because the patient has no vertical misalignment in the primary position. But because of the A pattern, weakening the superior oblique would definitely help her, even if it didn't correct the full problem, but at least it will correct the A pattern. And you can see, at least you can claim that it's like a left superior oblique overaction. So in a way or so, it would help the patient, even if it's not tight and even if it's not abnormally inserted, but at least it might be abnormally innervated. So weakening it would at least help some of the findings you see in this patient.
So regardless of the finding, you will go with the superior oblique myectomy, tenotomy.
Yes, but I don't expect that it will be normal. I mean, probably you'll find something.
Yes.
It will be tight, it will be short, it will be abnormally inserted. I mean, it's hard to find it completely normal, quite rare.
All right, we'll go to our next talk. Please stop sharing, Lujane. Very interesting case. Thank you very much. Our next speaker is Dr. Wajda Al-Hthal. I never had straight eyes, supervised by me. Please, Wajda, share your screen.
Okay, so thank you, Dr. Rashada, for the introduction. I'm happy to present this short case of an 8-year-old girl who presented to who presented for her first ophthalmology evaluation with a complaint of progressive ocular misalignment since the age of 1. There had been no prior ophthalmic treatment for this child, and she denied any double vision or decrease in her visual clarity. The patient had no significant past medical history and no known family history of strabismus or any other ocular conditions. This is how she presented to our clinic. She has an anomalous head posture. She's adopting a right face turn and a right head tilt of 4 and 7 degrees respectively. And you can appreciate the right-sided facial compression or mid-facial hypoplasia, which is more clear in the second image. She had a visual acuity of 20/60 and 20/30 respectively. Her cycloplegic refraction revealed mild anisometropic hyperopia and -1 cylinder. When we corrected her, she presented later and she could reach 20/25 vision. This is the extraocular motility and orthoptic measurements for the child. So you can see in primary position, and she's fixing with the left eye here. She has a left hypertropia in primary gaze. Her reductions in the vertical and horizontal gazes are within normal. In the oblique right gazes, you can see a left inferior oblique overaction of +4, and inferiorly a left superior oblique underaction of -2, and we don't see any reversal of the hypertropia in the oblique gazes on the left side. Her hypertropia increased on the left head tilt. For orthoptic measurements, she had an exotropia of 38 prism diopters and an LHT of 42 prism diopters. For distance, she had a 50 XT and a 35 prism diopter LHT. Her LHT increased on right gaze, reaching up to 50 prism diopters and decreased to 25 prism diopters on left gaze. She had no significant difference in the XT or the LHT in up and down gazes, so no identifiable pattern was appreciated. These two photos shows the position of gaze and the external photo of the child when she attempts to fix with the left preferred eye and the right eye. She couldn't maintain the fixation in the right eye for more than a couple of seconds to see the pictures, to take the pictures, but we can see similar findings: the LHT, the left inferior oblique overaction and superior oblique underaction, and no reversal of the hypertropia. Her fourth dot test, as expected, showed suppression in the right eye. Synoptophore and double Maddox rod was not able to be, the child could not perform them due to the large deviation she had. Her anterior segment was unremarkable. Fundus examination showed bilateral excyclotorsion with a total of 32 degrees approximately. At this point, we decided to do an MRI for the child to rule out masquerading conditions and to look at the superior oblique muscle tendon trochlear complex. This is a T1, the first image is a T1 coronal MRI, and the second image is a T1 fat suppressed contrast enhanced MRI. You can see a discrepancy in size between the superior oblique on the right and left, where it's significantly smaller on the right side, and the inferior rectus on the right side is slightly larger, or quite large, compared to the left eye. When we compare it to normative values, we can see that the superior oblique on the left eye is around 3 millimeters, which is the average, but it's significantly smaller, or 1 millimeter smaller on the right side. And there is a 1.5 millimeter difference between the inferior rectus between the right and left eye, where it's larger on the right side. So the most likely diagnosis for our case is a congenital superior oblique palsy, most likely bilateral. So I'm going to just go through a few points in superior oblique palsy. It is the most common palsy of the cyclovertical muscles. Most cases are believed to be congenital. Children usually present with a hypertropia and a compensatory head tilt, where adults present with diplopia and asthenopic symptoms after they decompensate their fusional amplitudes. The exact cause remains ambiguous. Studies using high-definition MRI propose two main mechanisms. Either the trochlear nerve is absent, resulting in a superior oblique muscle atrophy, which is considered part within the spectrum of the CCDDs, or that the trochlear nerve is present and the abnormality lies in the superior oblique tendon, which is the case in the majority of congenital cases. The main diagnostic features is the early onset without an inciting event, severe torticollis and facial asymmetry, marked superior oblique underaction, and large vertical fusion amplitude, especially when they present later. Unilateral versus bilateral. Well, bilateral cases usually have large excyclotorsions and small primary position deviation. Those patients typically adapt a chin down head posture to accommodate for the V pattern esotropia, and most importantly, they have alternating hypertropias on opposite head tilts. The diagnosis of bilateral superior oblique is not quite straightforward in most cases, as a lot of patients develop inferior oblique overaction in the unoperated eye following unilateral inferior oblique muscle weakening for presumed unilateral superior oblique palsy. When this happened, it is termed masked bilateral superior oblique palsy, and it occurs in 10 to 30% of the cases approximately. This is a nice paper by Dr. Kushner that reviewed superior oblique palsy, 147 patients with superior oblique palsy, and he identified 28 patients with bilateral superior oblique palsy. He stratified those patients into a clear bilateral superior oblique palsy with reversal of hypertropia appreciated in any fields of gaze, either the oblique fields or head tilts, and then a bilateral masked superior oblique palsy where the hypertropia of the lesser affected eye is not present in any field of gaze. He also introduced a term of an almost masked superior oblique palsy where the three-step test was not performed in the oblique fields of gaze, so it's masked or almost missed in those patients. The patients with bilateral almost masked and masked superior oblique palsy were 9, and all of those patients underwent bilateral surgery, and they all obtained satisfactory results. And interestingly, the cases that were diagnosed as unilateral only did not develop any unmasking of their superior oblique palsy, so they were truly unilateral cases. Dr. Kushner proposed that the two most important things to identify bilateral cases from unilateral cases is the alternating hypertropia seen in oblique fields of gaze or head tilts, and also to use objective measures such as fundus excyclotorsion to identify those patients. Lastly, I will just mention a few words about the role of imaging in the diagnosis. We all know that we order MRI for these patients to evaluate for the anatomy, to evaluate for the superior oblique muscle tendon trochlear complex. But this is an important or interesting paper by Dr. Deemer that evaluated 17 patients with unilateral superior oblique palsy. And he identified that those patients usually have a contralateral inferior rectus hypertrophy and increased contractility on functional MRI, similar to what we saw in our patient. He argued, or he proposed that this may explain why those patients may have large vertical deviations not explained by the superior weakness alone, and why those patients, a lot of them improve when we do a contralateral inferior rectus weakening or recession. All patients in his series underwent an ipsilesional inferior oblique weakening and a contralesional inferior rectus recession, and they all achieved satisfactory outcomes. So the main take-home messages from this case, we think that the bilateral congenital oblique presents with excyclotorsion and alternating hyperopia. Masked cases can be easily overlooked if the oblique fields were not assessed. Objective tools such as the fundus torsion may help separate the bilateral cases from truly unilateral cases. A suspicion of bilaterality should be aroused even if there is a mild overaction of the inferior oblique in the hypertrophic eye. And MRI is crucial not only to rule out mimicking conditions, but also identify anatomical changes in the extraocular muscles that directly impact the surgical management. Our plan for our patient is a bilateral lateral rectus recession to address the exotropia, a left inferior oblique weakening, and a right inferior rectus recession to address the vertical deviation that she's having. Thank you. And any input regarding our case?
Dr. Wadane, what are your thoughts?
Thank you very much. Okay, I have just a small problem with the movement because what we're showing only the versions. So I would like to test the elevation of the right eye in abduction because it seems that the right eye has limited elevation in abduction. So probably for me, this might indicate that the patient has like a kind of tightness of the right inferior rectus. I know it wouldn't make a difference because at the end you're going to weaken the right inferior rectus muscle, but I also feel that the right eye has limited elevation in abduction. So yes, it is an inferior oblique overaction, but I think on the left side, but I think over the long time, because the patient is fixing with the left eye, the patient developed a secondary tightness or contraction of the right inferior rectus muscle. Maybe it is a masked bilateral, but I mean, for me, what I would think of is that it is a purely unilateral left superior oblique palsy, but the patient prefers fixation with the left eye, the peritic eye. So the patient is always manifesting with a hypertropia of the right eye, and over time, the patient develops tightness of the right inferior rectus muscle, and this is responsible for the limited elevation of the right eye up and to the right. But to be honest,
The only thing that was surprising is the size of the left superior oblique. So the left superior oblique was larger on MRI compared to the right superior oblique, which had a smaller diameter.
Yes, I got so. Yes, I understand this. But I mean, it wouldn't change the treatment plan. I mean, for me, I would do exactly the same. I would do left inferior oblique weakening and the right inferior rectus recession, so it doesn't change anything in the plan. But I mean, this is what I thought of when I saw the photos in the beginning. Another thing, does the patient? You mentioned that the sign up to 4 didn't do a sign up to 4, or you did the sign up to 4?
We attempted. The patient, because of her large XT, the 50 degrees, and her large verticals, she wasn't really. She's very young. I don't think she was very cooperative enough for that test to be able to be done. We did try it, but we were unable to get anything useful from that.
You'll never be able to know whether the patient has a potential for fusion or not.
Fusion.
I mean, yeah, but if the patient has no potential for fusion, probably the patient would never show a left inferior oblique overaction, a left superior oblique palsy. So even if you did the surgery like what you preferred, I think that the patient would be hard to develop a masking or unmasking on the other side. I mean, the patient would just remain orthophonic in the primary position because she always prefer fixation with the left eye.
Definitely. Any other thoughts? I mean, I think the message from this case, why we brought this case, is the importance of fundus photos for torsion evaluation in these patients. I think it's very crucial. It's a very simple test. A lot of children can sit and take a fundus photo, and you can easily calculate the torsion amount. without any objective testing. I mean, it's very hard for them, especially with this large deviation, to do a double Medix rod. I think it's impossible. Fundus photos is very simple, very quick. You can quantify torsion as well easily with these patients, and obtain MRIs. MRIs are very helpful. I mean, the size of the inferior rectus muscle and that patient was significantly larger than the left, so it really guided us with the management. So we plan to do a right inferior rectus recession and a left inferior oblique recession as well. I think imaging and fundus photos are very helpful in evaluating these patients. Any other
One of the
thoughts?
difficult thing here is the surgical dose. I mean, because what we are measuring is the secondary angle, because the patient is always fixing with the left eye. So we are measuring the secondary angle. That is, we are measuring the right hypertropia. So, and you're going to operate on actually the primary angle and the secondary angle. So the left inferior oblique is going to work on the primary angle, and the right inferior rectus is going to work on the secondary angle. So it's usually very hard to judge how many millimeters exactly of the inferior rectus you're going to do. Do you have any specific plan for the surgical dose for the right inferior rectus?
I mean, she has 35 in primary position, 25 in down gaze, which is less, and that's where the inferior rectus will work. So I think a small recession should be able to do it. So a full recession in the inferior oblique of the left eye might correct up to 15 prism diopters, and then I'm left with 10 in down gaze. So I usually go 3 prism diopter per millimeter of recession. So I might do like a small 3.5 right inferior rectus recession and hope that works.
Good work. Good luck.
Thank you. Dr. Saif?
Yes. First, I thought that I was, a question was the patient operated or not, but seemed not operated until
No.
now. Yeah.
No.
And my question, why not myectomy? Why do you want to choose recession over myectomy? We know that myectomy has a more correction of the inferior oblique overaction than the recession. Is there a specific idea for that? Or?
No, I just prefer recessions. I don't think it's wrong. They both give equal effect from different studies that recessions and myectomies are equivalent. Dr. Awadain, what are your thoughts?
Yes, I like myectomy, but I mean, you're absolutely correct. Both myectomy and recession would work, so do whatever you like better.
I mean, recessions are reversible. You can, if you prefer to do recessions and the patient, let's say you have an infantile ET and you did a recession for an inferior oblique overaction, and then later in life they developed a DVD, then you can enterize it. I mean, it's still there. Technically, it can help you with correction of a surprise DVD in the future. So
This is
go ahead.
I mean, there is this about because I'm a huge advocate for myectomy, because so they always claim that myectomy is not reversible. There were studies that was done on patients who had previous myectomy, and you found that you can easily find the inferior oblique. It doesn't go anywhere. You're just taking a part of the inferior oblique, but it just gets attached to the sclera, just temporary to the inferior rectus. So even if you did a myectomy, it's still reversible. You can go ahead and find the inferior oblique, and you can do anteriorization later on or do whatever you like. It's
If
not
you remove
common.
10 millimeters, that would be very hard to retrieve and place it in a very good position.
Exactly, you'll find it exactly in the same place. I mean, I have many patients that I did myectomy for. You can find it doesn't go anywhere. It will just, because there is a neurovascular bundle that is attached to the inferior rectus, so the muscle doesn't retract all the way nasal to the inferior rectus. It just go temporal to the inferior rectus. But I mean, this doesn't mean that recession is not any better. I mean, they are equally the same, and both of them are, for me, are reversible.
Okay. There are some questions from the audience in the Q&A. There's a question that says, how many millimeters of inferior rectus recession from the inferior rectus? Well, there's the Parkes location, and there's, I mean, if you go 5 millimeter posterior to the inferior rectus and 3 temporal, that's where I always go, 5 posterior and 3 temporal. And if I wanted to enterize, I never exceed the inferior rectus position. To correct, like for a DVD, I don't go anywhere beyond the inferior rectus. So I don't do a J deformity or anything else like that. I think it limits elevation and it doesn't do any better. There's another question by Dr. Ganesh. With the patient fixing in left eye, is that left hypertropia more in right, left tilt? Don't get the question. Lujane, if you can help me answer this question. So the patient prefers the left eye and has it, and it's a larger angle when she fixates with the left eye. Actually, if you can see from those photos, I mean, Wajda, if you can help me answer this question. So left eye fixating, which is the preferred, has a larger vertical deviation, as you can see. If she fixates with her right eye, then the deviation is much, much smaller, but that's not her preferred eye because of her refractive error. We did correct it and it reached to 20/25 vision. We did give her glasses to initially. We're going to remeasure her after she wears her glasses, but I don't think those patients will ever fixate to their non-dominant right eye ever. Dr. Awadin.
Yes, I have a question about the primary angle and secondary angle that I mentioned before, because as Dr. Suma Ganesh mentioned, when the patient is fixing with the left eye, you get a large right hypertrophy because this is the secondary angle. But when the patient is fixing with the right eye, you get the primary angle, which is much smaller.
Much smaller.
Yeah, so what was the primary angle? I mean, when the patient was fixing with the right eye, what is the magnitude of the left hypertropia? Were we able to measure it?
Yeah, I got your question. The problem is the patient could not really hold fixation with the right eye, even for a couple of seconds. Even taking those pictures, we had to cover and uncover at each photo to take the picture. It was really difficult for her to maintain the fixation.
Which fixation?
Right eye.
Yeah,
Even
but you
with
can just place the prism in front of the left eye and do a prism uncover test until the movement stops. You just need to place a prism base down in front of the left eye, and this is how you are getting the primary angle. You don't need the patient to actually fix or maintain fixation unless you're doing a Krimsky or something.
So we'll
So I
bring
mean
her in.
that you measure the primary angle, because if the primary angle is small, this implicates that you should reduce the surgical dose on the right inferior rectus to avoid overcorrection, because you're working on the left inferior oblique, so this would correct the primary angle, which might not be that large.
Yes, definitely. It's not that large. I mean, you can tell from those pictures, actually. All right, we'll go to our last case. Stop sharing, Wajda, please. So last but not least, do image findings define the surgical approach in orbital floor fracture by Dr. Ala Samahi from King Khalid Eye Specialist Hospital, supervised by Dr. Sesma. Please, Ala, start to share. The microphone is yours.
Assalamu alaikum. Good morning, everyone. It's my pleasure to be here in this meeting, and I would like to thank my supervisor, Dr. Sisma. Today, I will present a case to see if the imaging findings define the surgical approach in orbital floor fracture alone or not. So the history, our patient is a 37-year-old Saudi gentleman, medically free, non-smoker, came to the clinic complaining of binocular vertical diplopia, chin up, and lower displacement of the left eye, hypotropia, more than 15 years ago, and he had a history of car accident in 2006. Past ocular history in 2006, he came with a hypotropia, 60 prism diopter. The vision is acceptable. The IOP was in the normal limit, and he visited the oculoplastic team, and he decided to do exploration of the left orbit, plus orbital floor repair and periotomy in the left eye. He came back in 2014 with the more hypotropia, around 90 prism diopter with double vision, and he did MRI and CT. Both showed an inferior rectus muscle being slightly enlarged on the left side with evidence of muscular fat prolapse. He did a second intervention, which is orbital floor adhesion repair and release of the adhesions of the globe inferiorly, but still there was no progression. He came back in 2022 with same complaint, hypotropia and vertical double vision. This is the 9-gaze photo of this patient. We can see in primary position significant hypotropia of the left eye with mild ptosis and significant limitation of supraduction in the left eye. The horizontal movement was intact. We did for him a CT that showed mild thickening and relative fat infiltration fibrosis growth into the left inferior rectus muscle with infiltration of the related part of the fat and fibrotic changes extending approximately 22 millimeter from the anterior orbital ridge. And I would stop here and ask you, our panelists, what is the best next step for this patient?
I actually thought there was an error in that MRI. I didn't get how the lens came down here in the coronal sections. I've never seen this before. I think this is the worst vertical deviation I've ever seen. So, Dr. Awadane, what do you think?
Well, I would like to know whether there is still any evidence of entrapment of the inferior rectus. I mean, just being scarred and fibrotic, or like an Addison syndrome, or there is an actual entrapment of the inferior rectus. But even though I don't think it would make a difference, I mean, even if there is an entrapment, I don't think it can be retrieved now. So probably I would just go ahead and do a force reduction test and proceed with an eye muscle surgery. I mean, I can't think that there is a role for the oculoplastic surgeon now. At least it's my impression now.
Yes. Dr. Sesma?
I'm asking to you, we face the patient.
What were your thoughts when you saw this patient? I mean, the MRI is really interesting.
You know, the reason to bring this patient is, well, you see the lens down, no?
Yeah,
Unbelievable. And when the patient came to our clinic, you know, was with no hope, no? The oculoplasty says no more, CTR says no more. But the reason to bring this case is based in that we have in our algorithm, we think that if you have a patient with a history of orbital floor fracture, and you have adhesions and you have things that you can find that can induce restriction in the floor, most probably the cause is there. Most probably that we need to check is in the orbit and not in the eye. So that's why we brought it. Ala, you can keep going.
Okay,
Go ahead.
Thank you. So we decide to do a third intervention, joining our colleague in oculoplastic team. To do orbital floor adhesion repair plus inferior globe adhesion release plus exploration of inferior rectus and with force reduction test. This is the patient on table. The oculoplastic did the adhesion release, but still the patient was hypotropic on the table. So Dr. Tisma and his team did force reduction. It was positive. So we decide to do exploration of the inferior rectus muscle and recession for the inferior rectus muscle. And this is the immediate result while the patient on the table. This is Dr. Assessment OR. So this is a first visit in the post-op clinic. We can see the significant improvement of the hypertropia of the left eye. Okay, so to discuss our case, we found out that even after exploring of the left orbital floor and release of the content entrapped, the eye was still on remarkable hypertropia. So we did a force reduction test and it was positive even after the release of entrapped tissue. We realized that the force reduction test was positive due to fibrosis of the inferior rectus muscle and not only by the entrapped fat and tissue. We conclude that a positive force reduction test is not always due to the entrapped, but could be also due to fibrosis of the inferior rectus muscle after a history of trauma or even more after a history of orbital floor fracture. So to take home message from this case is the force reduction test is the gold standard to making a decision in such cases beyond the images, and to do force reduction test pre and post operation while the patient on the table. Thank you.
Thank you, Ana. The idea of the case is that explaining that many times we have the tendency to overestimate the images and underestimate the clinical. So the whole message is the the FDT is the queen or the king of the test in these cases, and we need to do it and repeat it every time that we see patients that have history of orbital trauma. Usually when we see these patients, for example, in KCASH, is okay, the patient has something in the orbit, you see that is restriction, send it to oculoplastic and they take care of this one. And I disagree with this approach. I think that most of the time could be related to orbital for fracture. However, at that moment, oculoplastic enter, did the procedure in 5 minutes, says, okay, it's released. Okay, it's released, but the eye keep down. So the traction test is the response to this case. In this case, we found that the inferior rectus was fibrotic, was contracted, the inferior oblique also was involved, like a mass of tissue. So we recessed the inferior rectus recession, like a handbag suture. And then in the post-op, you can see that the patient has limitation for elevation. Probably the patient has also associated a partial third nerve involvement because involvement of the inferior oblique. You see that the patient has limitation for the elevation, has an XT. We later correct the XT, but the patient was happy and no diplopic in this position. So despite the fact that, again, the message is forced duction test is the queen or the king of, in this
How
case,
positive was it? Were you able to elevate the eye beyond midline?
Mafi.
Mafi. Nada. Okay.
Nada.
All right. So how much of a recession did you do for this patient?
In this
I
case,
don't see much of a lid retraction on the lower lid, so it's impressive. How much did you do?
was more than 7.
Oh, wow.
Was around 8 millimeters until I feel that the globe was. So I leave it. Was difficult. I think Omar Khan, one of our fellows now, I think he's where we struggled because this muscle was so contracted. It's like doing surgery in a Mobius or in a orbital thyroid disease that you have the muscle. So we were very careful. Almost to pass the hook under the muscle was difficult. So almost was passing the sutures, and this tissue that represent the muscle was cut carefully and leave it. Nothing like a modified handbag, just passing the sutures to insertion and leave the inferior rectus. And we
relax where it wants to
relax,
reside.
and we felt when the muscle was, we say, okay, we made it.
You didn't think of doing a resection to the superior rectus, for example, to help?
No, at that moment, no, because based in the induction test and based in the usually I expose both eyes, I compare the height of both eyes was similar. Say, okay, let's do this one and let's see if later the patient needs something else, we'll do it. Later in the post-op, we realized that the patient was having an XT and limitation for elevation, but was in the second stage. I mean, probably because the accident, because the history. But when you have an eye that the muscle is trapping the eye down, so.
So do you do intraoperative spring test?
But in this case, usually I do a sprint test as all my patients. I mean, like a routine, no? But in this case, no sprint test. I mean, you cannot move the globe, and that's why. Just imagine hooking the inferior rectus in this position. I mean, technically, so difficult. Look at the globe is looking the floor of the orbit, no?
So tough. Dr. Saif, you have a question?
Yes, my question to Dr. Sisma, did you find the inferior rectus in position, like 6.5, 7 millimeter from the limbus, or
yes, was in the position, but I would add that the inferior rectus was in position, but if you follow the inferior rectus was fibrotic, all this tissue was fibrotic and including a part of the inferior oblique. That's why, so you couldn't differentiate the tissues, was a mass of tissue there. The insertion was normal, however, when you follow the muscle was not normal, absolutely not normal, just fibrotic
and how were you able to secure the muscle with a suture? Was it risky to have a rupture, or how did you?
In this case, I did like okay, something that is red, that's the muscle. Something that is not red, that's the muscle. So we use non-absorbable sutures to pass to secure the tissue, and I could identify the level of the insertion and I didn't cut near to the insertion. I sacrificed a little muscle just to avoid perforation of the sclera, knowing that this muscle was very, very tight. So I sacrificed like a couple of millimeters of the inferior rectus, and I passed the sutures back to this distance, around 3 millimeters, 2.5, 3 millimeters, to allow me to start cutting the muscle carefully.
Okay. Good job.
Okay, Dr. Khan?
Very interesting case, Dr. Sisma. Thank you, Dr. Ala. We can see that this patient had the trauma at 2006 and now fixed at 2000, maybe 22. So the point, yes. So the point that you mentioned, Dr. Sisma, is very important. Like our oculoplastic colleagues, when they do the release of the entrapment, they should do the force section. And actually, if they cannot do it, they should involve us and keep us with them to do that during the first procedure. I think this patient, if the first procedure was done like with the strabismologist, maybe all of this was released. And also, like you can see, the amount of hypertrophy is so large because of the fibrosis all over all those years. We don't expect that all of this will be at the first time, but I expect that this happened over all those years. The inferior rectus basically is not working anymore. It's just fibrous tissue. So
I agree with you. I mean, I think pediatric ophthalmology should be involved from the beginning, and we need to do the force reduction test as a rule. I mean, the whole message of this one is that we have the tendency to think, because we see images in the floor that are saying that it's inflammation, entrapment of tissue or whatever, probably the cause is there. Well, the cause could be beyond of this one, and that's the simple message that we want to transmit.
Dr. Hind, you have a question? Go ahead.
Yes, Dr. Sisma, do you consider like injecting Botox in the inferior rectus just to decrease the tension?
No, at these moments, I don't think that the Botox was the option, because I was suspecting that something else was happening, and that's why I entered with the oculoplastic team, no? And if you suspect in a long-term period of time, probably the muscle is so contracted, so probably the effect of Botox is not going to be, effective. Something that you face in patients with long-term, for example, infantile isotropia, long-term isotropia, the Botox, the failure sometimes is due to the contracture of the muscle, no? So in this case, I didn't consider as a first option. I decided to go for surgery immediately.
Dr. Sheikh Al-Muammari, a question from the chat. How's the vision after surgery to the left eye? She's wondering.
The patient is fine. The patient now is my friend.
No, the vision. Sorry.
The vision. No, and that's why that was the other. The vision is good, and that's why the other part that was challenging. No, most of the times when we face patients like this one, this patient has poor vision or low vision, but this patient had good vision in all the moment, and I think that's why many he visit all Saudi Arabia, so probably many of you know the patient. So it's difficult to accept this patient because it's challenging, with good vision. I mean, how can you secure regarding diplopia after surgery or not? I mean, I spoke frankly with the patient, and he accepted, and we took the risk to explore.
Does he have double vision? Because with this good vision, I was wondering, how did you measure it in the first place? The globe is so down there. How did you actually measure his vision in the first visit?
He has
That's a challenge. That's a real question.
If you retract the glove, he can see from down, no?
With very huge chin up position. Probably. I don't know how you got the globe to any functional vision when it's really down there in the orbit. So we have another question from Dr. Manal in the chat. For significant hypertropia, do you recommend to do 2 muscle R&R instead of releasing inferior rectus alone?
I think that we have expert people like you and Dr. Ahmed, and many people here are expert that can. I think that in cases of restricted strabismus, secondary to fractures, to infiltration, to orbital changes, probably the first thing that I would do, more than be thinking in the classical tables to measure it, is go for the restriction, check the restriction, check the reduction test, and probably I would go, in this case, for example, I just went for the inferior rectus recession. That's it. Because probably
7 millimeters.
I mean, I don't follow these rules of according to the angle and according R&R. No, in this case, go for the restrictive problem, try to solve it first, and then later, if you need, I advise the patient that probably he could need a further procedures, but I go for one muscle and that's it.
Dr. Aldan?
Yes, a very nice case, Dr. Sisma, and very interesting and excellent outcome. I have a question that I always get asked for by my fellows. In patients with restriction, we know that we are going to release the restriction, but as you mentioned, we don't have a nomogram. We are just going to release it, and usually my fellows and my residents ask me, how many millimeters are going to place the muscle? So sometimes you might rely, for example, on the relaxed position of the globe. You just let the muscle and see where it's going to rest. You can do the spring back balance test, put the sutures on a bow tie. You can do an adjustable sutures, or you can just use your own judgment. So what do you actually do?
You know, that's the phrase that you mentioned is probably the clue. Where the muscle wants to be, probably that's the position of the muscle, no? As a in these cases of restricted, no? I like to use adjustable sutures, no? Unfortunately, in the Middle East, I don't know. I mean, the population that doesn't help me a lot to proceed with more adjustable sutures, no, because require a little cooperation. But if you ask me what is my preferred approach to these cases, is leave the muscle, as I told you, this muscle, I leave it around 7-8 millimeters from the insertion, and to feel more happy about what I want to do, probably I would do adjustable sutures because allows me to do the adjustment. And keeping in my mind that usually this adjustment, especially in the inferior rectus, induce late tuber corrections as a rule, no? So that's why if you ask me what is in this case, I couldn't do adjustable. I just place it at 7.5-8 millimeters, and that's it.
Yeah, Dr. Omar Khan on the chat says, I was with Dr. Sessman surgery. It was not only fibrose, but also adherent to the sclera in a large area. So he has this comment. There's another question about doing the remaining hypotropia and the XT. So I think you answered that. You said that you did later a recession in lateral rectus.
The hypo was not big. It was around, I don't remember in details, but was manageable, like around 7 piston diopters, 8 piston diopters. The XT was managed with lateral rectus recession.
And did you follow him up for a long time? Did he do well?
Yeah, I tell you, he's my friend.
friend.
He's my friend and my family now. He comes.
All right, great. Thank you all for great cases. Can you stop sharing? We would like to take one picture, a capture of all of the speakers as a memory. Please, everybody have your camera on and have a big smile. And thank you all. Thank you. Thanks.
Thank you all.
Thank you.
Take care. So we're looking forward to more talks and more meetings to come. Thank you all for joining us. Thank you.